In Part 1, the health and care system was characterised with reference to two axes of need. One describing the way in which citizens' needs are divided into broadly medical or broadly psychosocial, and the other capturing the system's tendency to see need on a sliding scale from low or simple to high or complex. It was proposed that the frame these two axes create explain in very large part the high levels of failure demands citizens are placing on the system, as well as the ongoing frustration of attempts to materially improve the system as one whole. Even accepting this analysis, it can be tempting to think that today's improvement approaches are acting on the right issues. For example, early intervention approaches would seem to address the problems created by the horizontal axis, ensuring that support is available to prevent the escalation of low-level needs. Similarly, addressing the vertical axis, integration approaches would seem to exist in direct acknowledgement of the fact that people don't need helped or fixed, but they need helped and fixed. However, the critical point to note is that neither integration nor early intervention does anything to challenge the logic of the axes themselves. For example, early intervention approaches de facto treat the focus as being on needs, not strengths, then seek to locate the citizen on the axis of severity of need. In Vanguard studies, maintaining this focus on need locks in dependency, ultimately serving to inflate demand on the system, the very opposite of what early intervention approaches are intended to achieve. Integration approaches, on the other hand, do nothing to challenge the vertical axis. Take, for example, the work design in a well-regarded NHS trust, which has rigorously pursued an integration agenda. Previously, there had been separate teams, managers and front doors for each of occupational therapy, physiotherapy, community nursing and social care. Each team had its own performance measures too. These teams were co-located and an integrated referral desk was developed. An integrated manager post was created to oversee the new team, and the social care IT system was changed so that nurses, OTs, physios and social care could all record into the same system. Important people visited and declared that the new integrated setup was a wonderful achievement. But from a citizen's perspective, how much had really changed? No question, the single front door was an improvement, but as soon as a referral had been taken, it was allocated into separate lists for OT, physio, nursing and social care. For each specialism, there was a professional lead, there to ensure that the standards and values of their profession didn't get lost in the new integrated arrangements. These professional leads would manage allocation into their profession and were responsible for ensuring performance against the appropriate measures, the majority of which had been carried forward from the pre-integration performance regimes. As a consequence, priorities and perspectives continued to be largely dominated by which profession you worked for, as was evidenced when one OT was asked what integration meant to her. "Now," she said, "we get to keep our milk in the same fridge." Like early intervention, integration approaches start with the wrong question. Where early intervention approaches ask, "What are the needs?" and thus build dependency, integration approaches ask, "How do we join things up?" and thus miss the opportunity to design for what's needed. The consequences are a system which is governed by the same frame, perpetuating the same type of system into the future, and so perpetuating the same type of performance into the future as well.